case of warfarin poisoning, you give Vicasol, that's vitamin K. In case of heparin poisoning, you give protamine sulfate. Then the next question was about an antihistamine H1, right? So the one which suppresses the central nervous system, I'm talking about the drugs which are in Krok, right, is Dremedrolium, right? And the one which does have the effect on the CNS, you can give the patient if the patient wants to be awake, is Loratadine, that's H1, right? H1 in the respiratory system. There is another drug also which suppresses the release of histamine from the mast cells, right? So it keeps the histamine contained. That drug is called Ketotifen. Ketotifen. Okay, there is another drug also which we use as a mucolytic, like to make the mucus thin. That drug is called Ambroxol. Another drug with similar effect is called what? Acetylcysteine. Right. There's another drug, an anti-cough with central effect, is called codeine, like codeine based. Right. Okay. Let's go to the GIT. Right. So GIT, the first thing you need to know the cells. Right. So we have chief cells. Chief cells are responsible for synthesis of pepsinogen. Right. Pepsinogen is converted to pepsin in acidic environment, right? So this acidic environment is caused by what? HCl, hydrochloric acid. Hydrochloric acid, which is released by the next group, the parietal cell. The parietal cell, it also releases what? The intrinsic factor. Intrinsic factor for absorption of vitamin B12, right? Then another cell again is Paneth cells. The Paneth cells, they are found like on the bottom of the proper gastric glands. They are responsible for like synthesis of a specific compound called defensins for attacking the what? It's more like an antibiotic. Right? It attacks bacteria. Okay, then another thing. All right, back on the particular cells. I talked about intrinsic factor, right? So extrinsic factor, the substance known as extrinsic factor is cobalamin. That's vitamin what? That's vitamin B12. One more time. If it is not available, the patient will have which kind of anemia? The patient will have megaloblastic anemia, right? And also there is another vitamin B9. If it is absent, the patient can also have megaloblastic anemia, right? The other name for B9 is folic acid. So how do you differentiate between the clinically the patient will, if the patient presents with neurological symptoms, you will know that this is specifically caused by vitamin B12 deficiency. Right. Other than that, in case of vitamin B12, there is what do you call? All right. How you do differentiate vitamin B9 and B12 megaloblastic anemia? For now, I just want to focus on folic acid. So if you say like homocysteine, if it is high, then you know that it's particularly caused B9 or folic acid deficiency. Right. Okay. That's like those two enzymes, those two vitamins. I mean. All right. So, okay. Shifting on the vitamins again, there is fat soluble vitamins A, D, E, and K, right? So they need what? They need bio for their absorption because they are fat soluble. If there is any kind of like a disease which obstruct the hepatobiliary system, the patients will have like malabsorption of those vitamins, right? Vitamin A, D, E, and K. Still on diets, like there is another vitamin called biotin, vitamin B7. If the patient is eating boiled eggs or raw eggs, these like these eggs, they have avidin. Avidin is a molecule which binds it binds to biotin, so that biotin will not be available for absorption. Right. Another vitamin which I want to talk about is vitamin B3 or niacin. Right. This vitamin is synthesized from tryptophan. Tryptophan. Another name for right. Okay. You're a tryptophan, right? So tryptophan is like a neutral acid which is responsible for synthesis of another thing other than nicotinic acid or vitamin B3 or niacin. That compound is called serotonin, right? Serotonin is a neurotransmitter. Another name for serotonin will help you remember tryptophan. It's called 5-hydroxytryptophan, right? Okay, in terms of vitamin B3 deficiency, it's usually caused by, firstly, this condition called heart-nappe disease. If the patient cannot absorb tryptophan from the intestines or from the kidneys, then the patient will have a deficiency. And then another one is Carcinoid Syndrome, because I told you that it is two pathways, like from tryptophan. Tryptophan synthesizes both what niacin and serotonin. So in Carcinoid Syndrome, there will be more serotonin. So there will be less tryptophan available for synthesis of what? Of nicotinic acid or niacin, that's vitamin B3, right? Then what else? That's about vitamin B3. Okay. Yes. Then vitamin B1, thiamine, pyrophosphate form. All right. So this one, is mainly deficient in people who are like with malnutrition, but in most cases, chronic alcoholism, right? Those people who drink too much, they're at high risk. And also there is like polished rice, right? It's another condition, right? So I'm just telling you, these are the pathways found in Krok, right? So the patient will have symptoms like what the Korsakoff syndrome is one of the is one of the symptoms of vitamin B1 deficiency. Another one is called beriberi, right? Beriberi is dry and wet. Dry beriberi is usually represented by neurological symptoms, and wet beriberi is usually edema, right? Okay, so why? Like these vitamins, vitamin B1, and vitamin. All right, okay, let me do it this way. All right, so after glycolysis, as a result, we have pyruvate, right? So pyruvate is different pathways, whether there is oxygen or not, right? Let's say there is oxygen, it will be converted to acetyl-CoA, right? That's the transitional pathway or transition step, conversion of pyruvic acid or pyruvate to acetyl-CoA. All right, so that reaction, it occurs in the mitochondria and is mediated by pyruvate dehydrogenase complex. That's the enzyme. All right, that enzyme is five core enzymes. Five core enzymes. All right, that's why I had to stop when I was trying to explain the vitamins. So the core enzymes of this pyruvate dehydrogenase complex can be remembered by the mnemonic, the lovely coenzymes for NADs. Thus, thiamine, lipoic acid, coenzyme A. Coenzyme A is from pantothenic acid. That's vitamin B5, remember. Then flavin, that's riboflavin, vitamin B2. Then the last one, which I just explained, niacin or nicotinic acid. Right. So there is a metal called arsenate. Right. Arsenate is a poison. It usually poisons the lipoic acid. Right. So that's how they ask this question. And you also need to remember another enzyme, whose structure and also coenzymes is just similar to pyruvate dehydrogenase complex. That is alpha ketoglutarate dehydrogenase. Right. Okay. I think we are done with this transition step and the vitamins associated. There is another vitamin called vitamin K. It's very important. It's a fat soluble vitamin. Usually in babies, like newborns, is usually absent. So babies they get like this intramuscular injection of vitamin K. Why is that? Because in newborns, this vitamin K, like in adults, is produced by microflora in the intestines, but in babies they don't have this. That's why we need to give them intramuscular injection. All right. What's the function of vitamin K? Vitamin K is needed by certain clotting factors. All right. Which clotting factors need this vitamin? 2 plus 7 is equal to 9, not 10. So factor 2, factor 7, factor 9, and factor 10, they are vitamin K dependent, right? This vitamin K is responsible for this one. It's called gamma carboxylation of glutamic acid, right? And it's actually, I mean, that's the process, but it's actually a coenzyme for an enzyme known as epoxide reductase. Right? Then there is another vitamin, vitamin A. I'm sure you know it. It is like the active form retinol, and also there is retinoic acid, right? So those two are for scotopic vision, and then things like transcription, respectively. Other things include like prevention of metaplasia, and also is responsible for like epithelial cell differentiation. Right. Okay. What else? Okay. Let's talk about like this bilirubin pathway. Right. So there is hemoglobin. Hemoglobin, you know, it's found in the what? In the erythrocytes, right? So erythrocytes, they live usually for 120 days, right? So on their death, they will release what? Hemoglobin. Hemoglobin can be broken down into what? Heme and globin. Globin, then amino acids, etc., then can be reused again. Then the heme part can be converted into biliverdin, then from biliverdin to bilirubin, and then bilirubin. In this case, bilirubin is called indirect or unconjugated. So it's carried by albumin to the liver for conjugation. So there are different enzymes needed for bilirubin conjugation. One of them is it's called what? Uridine. Okay. In short, UDP glucuronil transferase, right? That's in short. So this enzyme is temporarily absent in newborns, so that's why they have neonatal jaundice, right? So in terms of types of jaundice, you need to remember this enzyme very well, because if there is any disorder in this enzyme, there will be high unconjugated bilirubin. That's the first thing. Second thing, like if there is other conditions like hepatitis, it means like the functions of hepatocytes will be compromised, right? So there will be kind of jaundice known as hepatocellular jaundice because there is no conjugated. So in that case, there will be high unconjugated bilirubin. Then the other one is obstructive jaundice or mechanic jaundice, right? So in this case, there will be like conjugated bilirubin will be high. If you check the color of feces or urine, they will both be alcoholic, right? Meaning to say there is no stercobilin or urobilinogen, right? Stercobilinogen and urobilinogen. Then the other thing you need to know is this hemolytic, if like hemolytic jaundice, if there is intravascular hemolysis, then there will be obviously high unconjugated bilirubin. Why? Because like there is a normal rate of these enzymes, right? But if there is intensive or massive hemolysis, it means like there will be the enzymes responsible for this work will be overwhelmed to some extent. That's why you will see both conjugated and unconjugated, but unconjugated bilirubin in this case will be very high. Okay, then going down, where are we with the GIT? Now we are at the level of duodenum. There is that's where the hepatopancreatic ampulla is. Hepatopancreatic ampulla is formed if there is a combination of what common bile duct and the main pancreatic duct. It's called an ampulla of Heta. It is on the descending part, duodenum, right? Then from there, we have what a jejunum and then ileum. Ileum, you need to know mecostevedoculum up from the ileum, and then you go down to what to the terminal part where we have the cecum, right? There we have a lymphoid organ known as the appendix. If there is any kind of inflammation, there will be what appendicitis. Now there is another question which talks about like the behavior or how the neutrophils will increase is because of intensification of leukopoiesis, right? Another question it talks about surgery of the appendix is same thing. Then ascending, colon, transverse, descending. Blood supply of those things, it already. But there is another condition, it's called what? Portal hypertension. Portal hypertension in terms of this blood supply. First thing, like the abdominal part of the esophagus, there's esophageal varices, and also you have down on the rectum, rectal varices, and then on the anterior abdomen, there is, it's called what? Caput medusa, where there will be an engorgement of the veins, right? Okay, those are, they're called what? Petrocaval anastomosis, right? What else do you need to know there? Okay, there is fatty liver, right? So fatty liver in Krok, they just say tiger liver. Then you need to know it's about fatty. It's fatty liver. And then there is another one. Like, what do we call it? This one, nutmeg liver. Nutmeg liver is venous hyperemia. Venous hyperemia. Okay. What else? Okay. In terms of staining, if they mention Sudan 3, just remember the feds. If they say there's another for amyloidosis, Congo red for amyloidosis. Okay. Then there is another thing in in the kidney is very important. There is a reason why I'm trying to join the liver and kidney, because the liver is different functions, detoxification, synthesis, for example, synthesis of things like angiotensinogen. All right, angiotensinogen is which can be converted to tension by renin synthesized by mineral cells. So after that, the angiotensin will be converted to angiotensin 2 by angiotensin converting enzyme. You need to know the drug which inhibits angiotensin converting enzyme is called they are just called inhibitors. And one example is lasinotrin, another one is ketotifen. So they both end with 3. And the main side effect of those enzymes inhibiting S is what do you call it? Coughing. The coughing is the main side effect. Right. So where were we? We are at angiotensin 2. Right. So this one has different side effects on blood vessels, vasoconstriction. On the posterior pituitary, it stimulates the release, not this, the release of vasopressin. Right. Vasopressin is produced by what? So that's vasopressin from supraoptic nucleus, and then oxytocin from paraventricular nucleus, right? So that's from the hypothalamus, but is stored in the posterior pituitary neurohypophysis, right? So I said angiotensin 2, it will stimulate the release of this vasopressin, right? Still at that, we also need to mention like osmoreceptors. If there is like low osmolarity, it also stimulates synthesis of, the release of vasopressin or ADH. Now let's follow the ADH. ADH has 2 receptors again, V1 and V2. V1, those receptors are found in the kidneys. They stimulate the synthesis of aquaporins so that the aquaporins will absorb water from the secondary urine back to the blood. So that will increase blood volume. Then that will increase the cardiac output and blood pressure. Then on the V2 will cause vasoconstriction, right? Then the third effect of angiotensin 2 is on the zona glomerulosa, the suprarenal gland. It stimulates the synthesis of aldosterone. Aldosterone will go to the kidney, right? On the kidney, it will cause like a reabsorption of sodium. So as you know, water is a slave for sodium. So it will absorb, and then that will increase blood volume, therefore increasing cardiac output and therefore blood pressure, right? So just remember those effects of angiotensin 2. Firstly, on the blood vessels, then on the neurohypophysis, and then on the suprarenal gland. Okay, so I just explained the renin, angiotensin, aldosterone system. All right. Okay. What else? Right. You also need to know like if there is what do you call high blood volume, if there will be distension of atria. So if there is distension, the blood the system has its way of reducing blood pressure. What does it do? The atria will release atrial natriuretic factor. So this one is the opposite effect of angiotensin, right? So it will reduce blood pressure in using like different pathways. All right. Okay, that's about blood pressure, relationship with kidney, etc. Right. Okay, let's go to inflammation because there is another thing which I just want to find out. During inflammation, you need to know two cells, the macrophage and the monocytes. Those two, they release what? They release interleukins, particularly interleukin 1 and interleukin 6. Interleukin 1 will go to the hypothalamus, resetting the, like temperature control. So there will be fever that way. And then interleukin 6 will go to the liver for synthesis of C-reactive proteins. Right. So those are the things which you mainly see during during inflammation. Okay, okay. What else? All right. Let's talk about another function of these two. Monocytes and macrophages. They are also known as what? Antigen cells. Right? Antigen represent their antigens with major histocompatibility complex type 2. They present to the T cells, and then the T cells will stimulate B cells to transform into plasma cells for synthesis of immunoglobulins. Right. You need to know Bruton syndrome. Bruton syndrome is presented by absence of B lymphocytes. That's the first thing. And also there will be low IgA and IgM. Yes, you need to remember that. Okay. So another one is DiGeorge syndrome. That one is called, it can be like thymus hypoplasia or agenesis. So thymus, T for T cells, right? So it's mainly for T cells. You also need to know like its relationship with the inferior parathyroid glands because they both originate from same pharyngeal pouch, lower parathyroid glands and what and the thymus. Then Bruton syndrome, I'm almost done. From syndrome. Okay, let's talk about the immunoglobulins. Like because there is IgE, right? IgE is mainly for like inflammation in allergy things, right? And then you need to know eosinophils. Eosinophils starts with E, just like IgE. Then you need to know IgG. IgG can be across the placenta, giving the baby passive immunity. Right? And then you need to know IgM. IgM is the first immunoglobulin to rise in case of infection. And then later, the IgG will then rise and stay there for decades. UBV infection, what will happen? If, actually, it doesn't tell you about EBV. It just says infectious mononucleosis. So you need to know that it's caused by EBV, and then in the serum you see like what IgM, yeah, increasing IgM. I'm sure that's the answer. Okay, it's a lot. I cannot finish everything in Krok, but these are the basic things which you just need to know.